We're here with Dr. Marty Makary. He's a surgeon at Johns Hopkins, the author of the book, The Price We Pay, and of course, he's the editor-in-chief right here at MedPage Today. Welcome, Marty.
Great to be with you.
100,000 deaths and counting. It's a sad milestone, but one that does open up some questions about the U.S. in terms of its public health, our preparedness, the relationship between the federal government and the states, and our healthcare system in general. So where do we stand now?
But I think we've learned a lot of important things. We've learned a lot about our preparedness. We've learned a lot about the regulations, including regulations at the FDA, which it's now clear that the regulations at the FDA really blocked testing. We lost a critical 6 weeks when Washington state researchers were trying to get an FDA approval through an emergency authorization. Matter of fact, one of the FDA regulators, as is described in an article in the Dispatch on FDA regulators and this crisis, they required the doctor to actually send a CD-ROM to follow up their electronic submitted application for the emergency use authorization for testing. So that we lost a valuable 6 weeks. At the same time, testing is not a silver bullet. It's important. Its value is particularly heightened in the early stages of an epidemic where contact tracing can really help contain things. We've seen sort of model executions of that in South Korea and other countries. But I think in general, we're going to look back and say, we had too many political opinions. We had too many members of Congress, too many political pundits on TV talking about their coronavirus predictions, talking about their opinions, and not enough doctors, not enough epidemiologists. And so I think that's one of the big lessons here. Hopefully we can learn. It's also interesting, we're learning a lot from the data, and the data has been slow to come out. We're learning that, for example, clotting, blood clotting is a part of this syndrome. We're learning that the ventilator management is different. We may not need to be as aggressive early. We're learning about differences in lung compliance with this infection from standard ARDS and other types of infections that require ventilation. We're learning about the post-viral syndromes in children. We learned about that late, maybe tragically late, although the death rate is still exceedingly rare and probably rivals that of viral meningitis. But, the basic data on case fatality rates by age, by comorbidity, by profession, by living conditions. We're learning that low-income folks living in crowded, dense environments, as is common in certain parts of the housing sector in the United States, are at very high risk. Public transit, the role of socioeconomic and demographic characteristics. We're learning about the so-called super spreaders. 43% of all deaths have been in nursing homes and long-term care facilities. In New Jersey, it's about half. So we're learning that there are these high-risk populations that we need to protect. It's just the data has been a little slow to give us direction on exactly what is the distribution of the case fatality rate by these various factors. If you look at super spreaders, it's a real risk in society. One person gave the infection to 65 people at one church service in Washington state. Similarly in Arkansas, we know that historically this is kind of how it works epidemiologically. With the Spanish flu, it was one chef that really delivered the virus on a crowded ship to Europe, to the US Army. And so the role of super spreaders is one that I think we need to be really keen on going into the fall because of that, the lessons that we've learned the hard way from this pandemic taking a heavy toll on meat processing plants, long-term care facilities, low-income, densely populated areas, mass gatherings. And we're also learning about the role of climate. It turns out that is a factor. We were not sure what the role is, and we're still not exactly clear on how much of a role climate plays, but it clearly is demonstrating a seasonality.
You wrote a piece in the New York Times that went viral. It said we need to evolve our strategy as new data comes in. What can we do? How can we change our strategy?
Well, look, I was one of those people calling for a postponement or closure of all non-essential activities going into this thing. And there were a lot of folks in infectious diseases and epidemiology and public health that said, look, we're not quite sure what we're dealing with. The possibilities are really ugly. And we could face horrible rationing at the doorsteps of our hospitals. Let's do everything we can, based on the information that we have, to really try to prevent horrible health outcomes. So we did everything, and I think it was the right decision, and I think we've saved hundreds of thousands or more lives because of it. But as we've gotten more data in, our strategy needs to evolve. And some of that data is very interesting. For example, it's safer to be outdoors than indoors. We told people to stay at home. We probably should have told people to stay on your property, or try to be in a yard, or try to do activities in parks or open spaces, or in areas that had not really experienced a viral burden in their community. They should have started to transition businesses to do activities outdoors. We told people to avoid beaches and close parks. Instead of recommending closing parks and beaches, we probably should have focused on masks early on. It turns out that viral transmission is driven a lot by the direct person-to-person droplet spread that we're now recognizing. So the data is coming in, and I don't think we should look back and play a blame game. We need to sort of make the best of this and really prepare for the fall. But we need to recognize that it's not one of these things where we entrench and dig into a position. It's not a matter of closure or opening. I think from a public health standpoint, we should really be thinking about how do we recommend standards, and how do those standards adapt to the local viral burden and threat in a community. But as we progress here, our strategy's got to evolve, and it should be informed by the data. And right now that suggests do activities outdoors when possible, wear a mask when you can't maintain the social distancing, redesign business processes, and we need to be sort of hyper vigilant to protect at-risk populations. And that probably should be our strategy at this point as we gear up for the summer. Summer's going to be a quiescent period. We're going to see a decrease in cases. We knew cases and hospitalizations were going to increase as the country reopens. That's expected.